next presenter is Dr. Dae Kim. He's a geriatrician and clinical investigator at the Hebrew Senior Life Marcus Institute for Aging Research. His presentation is entitled Comparative Performance of 4 Claims-Based Frailty Measures in the United States Medicare Data. And I'm going to hand over the podium to Dr. Kim. Please go ahead.
Thank you for giving me this opportunity to speak today. What I'm going to talk about for the next 20 minutes is how to measure frailty in administrative claims data to study health outcomes in older adults, including people with dementia. After submitting my title of the presentation, I modified my presentation, so the title is different from what was just introduced. The work that I'm presenting today has been supported by these various grants from NIA, and I do not have relevant disclosure related to this presentation. Before I talk about measuring frailty in claims data, I want to explain to you why we assess frailty from clinical perspective first, and then how well we can measure frailty from administrative claims data. And then I'll show you some examples, applications of claims-based frailty measures used for research, including analysis of health outcomes and costs associated with the dementia and frailty. So why we assess frailty? It is because frailty is a key determinant of health in older adults. Frailty is defined as a clinical state characterized by reduced physiologic reserve to maintain homeostasis and increase vulnerability to poor health outcomes after a stressor. It is a strong risk factor for mortality, loss of independence, other geriatric syndromes, including falls, dementia, and delirium, and excess healthcare costs and utilization. A number of validated tools have been developed to measure frailty in clinical practice. Some measures, such as Frail Scale or Questionnaire, Clinical Frailty Scale, or simple bedside tests, while others require measurement of physical performance or comprehensive geriatric assessment or CGA. Here is an example of a simple frailty assessment. Clinical frailty scale is based on a clinical judgment of fitness to frailty spectrum based on data such as disease symptoms, activity level, mobility, and disability. It ranges from stage 1 to 9, as shown in this figure on the right, and stage 5 or higher is considered frail. On the other hand, a comprehensive geriatric assessment-based frailty index requires review of medical history, self-reported functional status, nutritional status, and cognitive and physical performance, although performance tests are not mandatory. A frailty index is calculated as the proportion of abnormal items assessed, so it ranges from 0 to 1, with higher numbers indicating greater frailty. Many of these items already exist in medical records, but searching for that information and counting abnormal items can be cumbersome. Use of online calculators, such as the one shown here on the right, or EHR embedded calculator, can facilitate data collection and calculation. Because frailty is a measure of vulnerability, it can predict a wide range of adverse health outcomes in older patients. In addition, it can predict recovery after a stressful surgical procedure such as aortic valve replacement. We demonstrated this in a prospective study where we identified 5 unique patterns of functional status recovery pattern in the year after aortic valve replacement. Here, the y-axis shows the number of daily activities and physical tasks that one can perform without help. So the higher number indicates better function. Patients who followed excellent or good trajectory on the top recovered by 3 months and remain at that level of function for the remainder of the year. Patients following poor or very poor trajectory in the bottom remain impaired for the rest of the year. So how can we predict this trajectory of recovery? We use a baseline frailty index that was measured in a pre-op visit. And as an example, a person with a frailty index of 0.5 or higher is most likely to follow poor trajectory, but the best possible scenario can be fair trajectory, or the worst possible scenario can be very poor trajectory. A recent study from UK Biobank showed that people with frailty are more likely to develop dementia than those without frailty. In the study, they estimated that 8.6% of dementia cases could be prevented by reversing frailty, and 9.9% of cases could be prevented by reversing pre-frail stage. And another study that used a cross-sectional autopsy study from Rush Memory and Aging Project found that a large majority of people with high Alzheimer's disease neuropathology burden had been diagnosed with a clinical dementia regardless of the frailty level at their last examination. But among those with low burden of neuropathology, only people with high frailty level had been diagnosed with clinical dementia. So these data suggest that frailty may reduce tolerance of Alzheimer's disease neuropathology, and therefore patients with high frailty are more likely to be diagnosed with clinical dementia even when their neuropathology burden is not high. When a comprehensive geriatric assessment is performed, domain-specific impairment can guide clinical intervention. For example, for patients with high medical complexity and frailty, we can adjust disease management targets or stop treatments of unclear benefit or high risk of harms. For those with mobility impairment or muscle weakness, can benefit from exercise intervention and home hazard reduction to reduce the risk of falls. And occupational therapy and social services can be arranged for those with disability. And treatment for cognitive impairment and discontinuation of psychoactive drugs can be considered for those with cognitive abnormalities. A dietitian referral and nutritional supplement can be done to optimize nutritional status for those at risk of malnutrition. So to give an idea for a person with this deficit pattern, the graph away from the center of the graph indicates higher level of impairment. So for a person with this deficit pattern, we can recommend exercise intervention for their muscle strength and arrange support for to support instrumental activities of daily living. To summarize, frailty assessment offers a unified framework for risk prediction and prognostication in older adults, including patients with memory problems and Alzheimer's disease and related dementia. Based on frailty information, we can intervene to improve frailty and function itself, or make decisions about other stressful treatments. So now I'm going to talk about how well we can measure frailty from administrative claims data. Here are some of the reasons that we want to measure frailty in claims data. A frailty information from claims data can provide prognostication on a large population scale where clinical assessment is not feasible. Researchers can use it for case mix adjustment by frailty in a comparative effectiveness study and health services research. And we can use it to generate evidence from real-world databases on how frail patients benefit from a treatment differently from non-frail patients. In developing a frailty index from claims data, there are a few methodological considerations. Since Medicare data were generated from healthcare transaction, clinical information is missing, but it contains a lot of proxy information from diagnosis, procedure, and health services codes. When developing a frailty index using this proxy information, one needs to consider whether there is an external data set that contains a reference standard clinical frailty measure, how to select predictors from claims data using clinical knowledge or some data-driven variable selection method, and how to validate this index. In the next few slides, I will provide a brief overview of approaches that have been used by researchers in the field. The first approach is clinical knowledge-based selection. One can use diagnosis codes, procedure codes, and health services codes that are commonly used by patients with frailty, such as hospital beds and supplies, pressure ulcer, cachexia, wheelchair supplies, and diagnosis code like failure to thrive or debility. In general, this approach has high specificity and low sensitivity compared with the data-driven modeling approach that I will review on the next slides. The second approach is a data-driven predictor selection in the absence of a reference standard frailty measure. Dr. Gilbert and colleagues applied a cluster analysis based on the number of frailty-related diagnosis codes, healthcare utilization, and healthcare cost. It was presumed that the cluster with a high number of frailty-related diagnosis, high utilization, and high cost represent frail patients. However, frail subgroup may not be uniquely identified using this approach. In the work by Dr. Gilbert et al., 6 clusters were identified as shown in this table. There was one cluster identified as frailty cluster with high representation of frailty-related diagnosis and high 2-year mortality. But it is possible that acute heart disease cluster and cancer and lung disease cluster may also have included some good proportion of frail patients. The third approach is a data-driven predictor selection with a reference standard frailty measure. This approach is possible when there is an external data set with a reference standard frailty measure. One can build a model to predict the reference standard measure using diagnosis, procedure, and health services code in the claims data. However, choosing which reference standard frailty measure to use can influence the model performance. And here are some examples of claim-based frailty indices that were developed using different reference standard measures, such as ADL disability, frailty phenotype, and frailty index. And then the list of predictors are shown on the table. Of these claim-based measures, the one that we developed was modeled after a deficit accumulation frailty index, which ranges from 0 to 1. And in an independent data set, we showed a correlation of 0.59 with a clinical frailty index, a C-statistic of 0.78 for frailty phenotype assessment, and a C-statistic of 0.84 for having 2 or more ADL dependency. The program to calculate this index is made available in various statistical software in the link here, including SAS, R, and Stata. So now I'm going to show you how to apply a claim-based frailty index in clinical research. First, using a claim-based frailty index, we can predict important health outcomes for older adults, as shown here. The higher frailty was associated with higher mortality, long-term institutionalization, worsening, or new disability, hospitalization, and prolonged skilled nursing facility stay. We also studied how frail patients benefit from a new non-vitamin K or anticoagulant therapy versus warfarin differently from non-frail patients in patients with atrial fibrillation. We calculated the hazard ratio for a composite endpoint of death, ischemic stroke, or major bleeding. So in the first cohort, dabigatran was associated with a 9% reduction in the rate of composite endpoint in the overall population. But as you can see, the benefit was more pronounced in the non-frail population subgroup and almost none in the frail subgroup. Rivaroxaban was not significantly different from warfarin in the overall population, as well as across the frailty levels. Apixaban was associated with a lower event rate than warfarin in the overall population, as well as all frailty subgroups. Another study conducted by Dr. Johnston and colleagues showed that combining CMS-HCC model, which is used to predict cost, and claim-based frailty index improves prediction of total Medicare cost. This table shows the results of a regression model for Medicare cost using CMS-HCC model alone in the middle column, and the combined model with claim-based frailty index in the right column. After adjusting for CMS-HCC model, patients with a moderate to severe frailty was associated with almost $16,000 higher cost than non-frail patients. Lastly, I want to share the findings of our analysis that use claim-based frailty index to examine healthcare outcomes and costs by dementia and frailty status. So we use 5% Medicare sample of fee-for-service beneficiary, and we classified these beneficiaries into these 4 mutually exclusive groups based on the presence of diagnosis code for dementia and claims-based frailty index with a threshold of 0.2 to determine frailty versus non-frailty. So 1-year mortality was highest for those with both dementia and frailty, the column on the right, followed by those with either condition, 2 bars in the middle. Patients with dementia had a higher number of ICU stays, especially when they also had frailty. The number of days spent alive out of hospital and skilled nursing facilities, so-called home time, in the 1-year period decreased gradually with the presence of dementia alone, frailty alone, or both. Patients with dementia had greater total Medicare costs than those without dementia, but the frailty seems to be a major driver of total Medicare cost. It was notable that dementia diagnosis was associated with increased skilled nursing facility costs, which is the green bar, among patients with frailty. We also found a geographical variation in total Medicare cost per beneficiary for the 4 groups of patients based on dementia and frailty status. The range of total Medicare cost shown by these 4 groups. The cost variation was the greatest for patients with both dementia and frailty, ranging from $13,000 to almost $32,000. And this variation was much greater than patients with either dementia alone, frailty alone, or neither condition. So I'm going to conclude my presentation with these key points. Claims-based frailty index can be useful when a large-scale clinical frailty assessment is not feasible. It can identify high-risk, high-needs patients on a population scale, and it also enables evaluation of treatment outcomes by different frailty levels. Accumulating evidence supports consideration of frailty in clinical and outcomes research of ADRD. Therefore, effort to improve healthcare quality and outcomes and reduce costs should target older adults with dementia who also have high frailty level. Thank you for your attention.
Good. Okay. Dr. Kim, thank you for the very interesting presentation. And we have, it's 12:11, so we've actually got 20 minutes to go to the end of our morning session. So there were several questions. I didn't see any questions popping up directed to your presentation. I think it was very clear, the presentation you did, and yeah, I would say that the specifics of how to do the implementation are in the links you provided. So anybody who wants to replicate your measure can do so. I don't know if you had seen, I had published with my collaborators a recent evaluation of the Gen Frailty Index in the, what was it, Health Services Research. And so there are many different ways to implement the specifics. I think the key point that jumps out on your graphical presentation is that the combination of frailty with dementia really is almost a defining aspect of the need for high levels of care. And so I think people need to keep that or take that into account. If